everyone. Thanks so much for joining us for our weekly Hospital Association briefing. We really appreciate you coming. I'm Cassie Sauer. I'm the CEO of the Hospital Association. We've got some great panelists today. We've got three organizations represented, and one of which has a few people joining us. So first we have Darren Goss, who's the Chief Executive for Providence Health and Services Southwest, which is the Olympia and Centralia area. That's that part of the world. And he's going to talk about what's happening in COVID generally, and also what's happening in their vaccine outreach. We have Dr. Patricia Critic. This is something that a number of you had requested, that we think about getting someone who had special expertise in caring for COVID patients. Dr. Critic is a pulmonary and critical care physician, and she works with COVID patients at UW-Medicine. So we're excited to hear about that. And then we've got three panelists from Newport Health and Services and the Tri-County Health District team. So this is the area up sort of north of Spokane on the Idaho border. And those counties have been working really hard on vaccines for a very rural area. We have Christina Wagar, who is the Director of Operations for Newport Hospital and Health Services. Jenny Smith, who's the COVID-19 Incident Commander, also at Newport. And we're delighted to also have Matt Shans, who's the Administrator of Northeast Tri-County Health District. So they can really talk about the partnership between the hospital and the health district. So I'll start with just some general overview comments and then turn it over to our panelists. We continue to be very pleased with the decline in cases and hospitalizations for COVID around our state. We are definitely going in the right direction, and we hope we continue going in that direction. So I think an important message for folks who need other kinds of healthcare is that hospitals have room. So we're still concerned about people delaying care potentially who have a cardiac condition or might be having a stroke or had an injury. They should come to the hospital. The hospitals have room for them for sure. We've been able to care for those folks throughout the pandemic, but I think especially now, just the knowledge that the COVID cases are so far down, we want to make sure that message is out there. We had an interruption in our vaccine delivery last week. As you heard from the snowstorms in other parts of the country, we actually did quite well with our snowstorms here, that we were able to very few appointments had to get rescheduled, but those that did because of difficulty in opening our own clinics, they were just fine. What had to be rescheduled was that we didn't get the vaccine that delivered that we were expecting. So it sounds like people have gotten delivery notices. Vaccine is en route. Hopefully will arrive in the next day or two. There's going to be essentially a double delivery of last week's vaccine doses and this coming week's vaccine doses. Hospitals aren't getting a ton of first dose allocation for next week. And so I'm actually quite confident that on the hospital side, we are going to be able to work through our vaccine doses from both last week and this week quite quickly. So I think that's exciting news that we'll be able to get through both second and first doses in the coming week. So those are just some general opening comments about where we stand. And I'd like to turn it over to our panelists. Dr. Critic, I'd love to start with you. To talk about your experience in caring for COVID patients. What have you learned? How has care changed? How is your staff doing? All those pieces. Thanks so much for joining us.
Thank you. Thank you for the invitation. And as was just mentioned, I'm a pulmonary and critical care doctor in UW-Medicine. I predominantly work at UW-MC Montlake in the ICU there. And what I would say is, with the two different surges of patients that we've had, I think we've gotten better and better at taking care of patients. And as you just alluded to, the number of patients in our ICUs with COVID now is really down to the single digits. I think what we've seen and learned is that patients who end up in the intensive care unit and requiring mechanical ventilation are in the ICU for quite a long period of time. There are patients that we're making slow but steady progress on liberation from the ventilator, and really being patient and working through that as a team has been important for us. And I think we've gotten better at that over time. I think the other thing that's been challenging is those patients end up being longer length of stay patients. And in our institutions, we have not had families in our ICUs for the most part. So balancing caring for the patient and caring for their families over that duration of time that most patients are requiring critical support in the ICUs has been a challenge. I think we've gotten, as I said, better at partnering with families and using technology like iPads and other resources to help them see their loved one as well as be a part of our decision making. But still a challenge and still a part of, I think, what contributes to what's been a really hard time period for the critical care team. And I mean that I mean all members of the healthcare team in the ICU. It's hard to feel like you're making slow progress. And I think that is kind of more the rule than the exception. And we're getting there, but it feels slower than it does with a lot of other critically ill patients. The other thing I would add is one of the other hats I wear is I'm the co-leader of our well-being response during the pandemic in our institutions. And we're really been focusing on the well-being of our teams because I think that the duration of this time has taken a toll on all of us. We're trying to transition into recovery mode in the support of our healthcare providers and really thinking about increasing our mental health resources for our healthcare team in a partnership with our Department of Psychiatry, which is really novel and wonderful. Thinking about how we say thank you and express gratitude for people who've been really digging in deep for quite a while now, and thinking about how we create flexibility so people can continue to do all the other stuff which has been on people's plates as they've also continued to take care of patients. So I would say things are better. I think that feels really good. I think that vaccinations has changed the motion and the tenor of the folks in our ICUs. And I think people are super tired after doing this for quite a while. And so those would be some initial reflections, and I'm happy to add to that with questions as we move forward.
Dr. Kritick, I want to ask you a question. One of the things I am concerned about is whenever we say COVID cases are down and things are better, that people will think, oh, I don't need to wear my mask anymore. I don't need to social distance any longer. It's, everything's okay. And I think it's worth emphasizing how bad a disease this is, that you really don't want to get it. Like, even though the UW does a magnificent job managing patients, the notion of being on a ventilator separated from your family for an extended period of time is terrible. So maybe you could address that.
Cassie, I couldn't agree with you more. I think a couple things I'll amplify in what you just said. The first is, it is a disease that a lot of people still are dying from. And so we want to take that incredibly seriously. So I'm telling you about the people that were getting better, but part of the challenge for the critical care team is that folks have not survived critical illness and ARDS in the setting of COVID. I also think we have a vision of this being older folks with multiple comorbidities, and the reality is that's true. And I've personally taken care of very young people who have been critically ill and have not survived their admission to the ICU. So this is true for everybody. You don't want to get COVID. And while we're enthusiastic about numbers going down and vaccination, it's super exciting. Masking, physical distancing, hand washing, all those things that have gotten us, those are the things that got us here. That's how we got here. And so we want to stay true to those because, as you just said, this is not something that we want anybody to get. And it's happening to folks that are across the spectrum of the people in our community. And so still time to take it super seriously. Thank you for asking that question.
Thank you. All right, Darren, let's hear from you about how things are going in the Olympia and larger area.
Yeah, I think, thanks, Cassie. Similar to Dr. Kritick. So we're noticing the same lower trends here, and I couldn't agree more. I think it's the masking, the social distancing, and other initiatives that's helped us get here. And right now, it's a much better place to be than where we were a few months ago. So today, actually, at Providence marks at St. Peter our 1-year anniversary of being in incident command. That's a record I hope to never break again. And for those familiar with the incident command structure, that is your leadership command center to respond to an emergency or disaster. And we used to really struggle on how do you get incident command working for 5 days to 7 days. And now I just blown away. We're at the 1-year mark. And so that's still progressing. We've given about 20,000 vaccinations here at Providence, and really been working with our local leaders, our Thurston County, Lewis County Department of Health, to make sure we're getting the vaccinations into arms, both from an equity standpoint, but then also just to make sure, we have challenges with those who may not have access to an email account, a cell phone, especially those that may not be able to get to a vaccination site. So I appreciate the efforts from both Lewis and Thurston County to help us do that. But I recognize we have a long ways to go there from an equity standpoint. We have done about 7,000 patients that just needed to be rescheduled. Cassie, to your comment regarding the delay in vaccines. So we had about 7,000 we needed to move. We have received our Pfizer. We're actually starting that today. Moderna is confirmed, but has not shipped yet. And so I think like several hospitals, you're taking what were second doses, we moved them to first doses, and now we're taking some of the second doses or first doses and moving them to second, just to make sure we can wrap up these second doses for those that have that time limit. We've done about 34,000 COVID tests at our Hawks Prairie site here in Lacey. And we'll continue that effort here and also starting to talk through what's our long-term plan with our COVID testing site. And then from a COVID patient standpoint, we've had about 800 COVID patients total here at Providence Centralia, Providence St. Peter, and pleased to see those numbers are being more stable. We have about 30 patients today, 24 at St. Peter and 6 at Centralia. And that number has been fairly stable for us from a patient standpoint. And then from a mental health, I appreciate Dr. Critic talking through that. Our staff are tired. And I think, whatever we can do to continue the social distancing, masking. One thing we've done here is added a behavioral health concierge program here at Providence. And I think that has been helpful, and I hope it's helpful, because the mental health, behavioral health needs are just so diverse for our staff. And so we're interested to see if that plays a role in our caregiver health. And PPE supply remains fairly stable here. So happy to answer questions, and appreciate the coordination and relationship, Cassie, with Wisha. So thank you.
Thank you. All right, I think we'll go ahead and hear from the Newport team. Really interested to hear about the collaboration between hospitals and health districts. And I'm not sure actually which one of you would like to go first. So I'm going to leave it to you all to decide.
This is Jenny. I can go first. So first off, I just wanted to say thanks to Wisha for inviting us to be part of the panel today. I did change up my background a bit. That's a picture that I took from my yard of some moose that frequently come in, so that I thought would be nice to kind of illustrate the rural community that we live in and how rural Pend Oreille County really is. You did mention we are in northeast part of Washington State, close to the Canadian border. We have an older population, and many of them are very sick and poor. And so we do our best to care for this community with what we're given. In terms of vaccine efforts, it really has been a huge collaboration with Northeast Tri-County Health District, some of the other local rural hospital districts, including Ferry County, Stevens County, as well as even Lincoln County, in trying to coordinate these efforts with the vaccine that we're allocated. And it's been pretty incredible. Matt Shans is an amazing administrator for Northeast Tri-County, Sam Artsis as the medical officer. They've done a great job. And but really, it's been extremely refreshing to see the partnership and the communication and how quickly we're able to get these vaccines in arms. To date, Newport has given just over 1,400 shots. That is first and second doses combined. We have seen that we can quickly pivot once we discover that we are receiving an allocation. We've had to shift things a couple of times, but we have an incredible vaccination team. From the greeters to the schedulers to the nurses, the medical assistants, they've just done an amazing job. We have a courier volunteer who has been literally driving over the mountain to pick up our vaccine. And really, probably one of the most amazing collaborations is that, we are able to work with Ferry County Hospital because they do have an ultra low cold storage freezer, so that we can actually use some of the Pfizer when it comes and not have to do the dry ice. So there's been an awful lot of driving on everyone's parts. I will say we've still got At Newport, we still have 800 names on our list for people who have called and left messages or who have gone and used our online vaccine registration. And so we are working through that. And we've been able to utilize our vacated long-term care facility, to set up the vaccination clinic in a space that allows for social distancing and easy access, especially for those with limited mobility. We do have a significant portion of our phase 1B tier 1 population who really struggled with the concept of having to drive to Spokane to receive a vaccination at the Spokane Arena at one of the mass vaccination sites. And so for us, even though we're not able to pump out, 1,000 doses a week, we are able to serve our community with what we're given and hopefully, make things a little bit easier on those folks who can't easily get to the mass vaccination site.
Great, thank you. And I think an important thing, we had Aaron Edwards on a prior call. He's the CEO of the hospital in Ferry County. They use some of the CARES money they receive from the federal government to buy an ultra cold freezer. I think they're the only ones in that area that have an ultra cold freezer. Is that right, Jenny?
Correct.
So they've agreed to store vaccine for other providers. And as Jenny said, then they've got someone who drives over and gets it back and then they're ready to go. But it looks like, I think we mentioned this last week, that the state's distribution strategy may be that hospitals are largely getting Pfizer because hospitals have more ability to handle ultra cold. But just looking at the allocations this week, it looks like that is the case, that very few hospitals got anything but Pfizer as first doses. There's some second doses if they had Moderna before, but the first doses look to be largely Pfizer. All right, happy to hear the next member of the Newport team.
This is Christina Wager. I'm the Director of Operations here at Newport Hospital and Health District. And I'll just reiterate a lot of what Jenny said, and also a little bit of what Darren said. Here we are almost a year later in incident command. And I think, we can all try to say, obviously COVID is definitely a big bowl of lemons, but a lot of us have made a lot of lemonade out of it. And so we've identified that the partners that we have around us are really able to help us in crisis. And, a rural hospital doesn't have every resource available to it. And so we've always relied upon the community to help us out. And I will say unequivocally that I could not have asked for a better partner than Northeast Tri-County Health District and everything that they've done for us and our community here. And I can probably speak on behalf of Stevens County and Ferry County as well. Excellent communication, excellent partners. And so that has helped our community in indeterminate amounts of ways. The other thing that we've discovered is that, rural hospitals have always been very nimble because we're so small. And so definitely through the COVID crisis, we have identified that even though healthcare is typically very slow to change, this required us to change. And so we were able to get a vaccination testing tent up literally within a week. And we were able to get that up and running so fast. We were able to start the vaccinations literally in a week. As soon as we knew that they were going to be out, we had a clinic set up and running. And so it's because of all of the support and help that we've received from partners like the health district and just being able to ask questions. Everything is so unusual and unfamiliar that we need all of the resources that we can get. I don't have infectious disease here. So, we have to contact the partners that we've made around the state sometimes to be able to help us through some of this. And we've had exceptional partners with the University of Washington. We do have a physician on staff who he's a professor through the medical school. And so he was able to get us early help with all of the contacts at the University of Washington, enormous help. Providence facilities, when remdesivir first came out, they went through extraordinary lengths to make sure that we had some available for our patients. And so we just feel very cared for by the whole state, all of our communities. Yes, there have absolutely been some bumps along the way with the vaccine, but we're just going to keep moving on. And any vaccine we can get, we're going to get into arms as quickly as we can. So again, thank you to everyone so much for all of your help. We know it, we recognize it, we see it, and we appreciate it.
Thanks, Christina. And I think you're really highlighting something that we have said a number of times, is that this is among maybe the most, I'm not sure if it's the most, but certainly one of the most collaborative hospital communities as a state across the country. And you have absolutely seen it, and how resources, medications, staff, knowledge, patients, ventilators have moved around the state, that we never had a single hospital get overwhelmed. We've had different spikes in different communities, and 100% of the hospitals have cooperated with each other to make sure that every patient was cared for. And that is a huge accomplishment. All right, and Matt, we'd love to hear from the public health side, how things are going for you up in the Tri-County area.
Well, we appreciate the invitation to speak with the group as well. I'm sitting with Dr. Artsis, our health officer. He's across the room, but I'll cover the basics of just our partnership with the hospitals. In this, we are the only 3-county multi-county health jurisdiction in the state, and so our partnership extends to Pend Oreille County, Ferry County, and Stevens County. And it has definitely, as both Jenny and Christina have spoken to, been a partnership through and through. And that goes, all the way back a year from ago is when we started to have returning travelers come in from cruise ships or from trips to Italy, that we really, began this journey together, and we're still on it. With regards to vaccination, I think one of the challenges that we've had within a rural setting is that none of us are large enough really to effectively get out with current allocation of resources, a full allotment of Pfizer of 1,170 doses. And so, we, right before this phone call, we were truly on a call amongst hospitals and community partners, medical partners, about how we can transfer vaccine, both physically and through the electronic system at DOH, to ensure that we do our very best to get those vaccinations out, distributed, and effectively administered. So that's been really key, is that we've shared and coordinated on vaccination resources. I think where we're at right now is also trying to understand about, we know we have this current capacity to administer vaccine, but if we look forward into the end of March, and if we speculate that the vaccine allotment to the state could potentially double, and that we're at close to 500,000 doses, if that truly comes to fruition, what's our strategy? And so the work that we've done just in the last the last week and a half, has been about trying to coordinate with the state and standing up incident management teams, both at the state level. So if you're not aware of those conversations, the state is currently trying to establish a type 1 incident management team that will coordinate then with regional type 3 incident management teams. And so we've made that request for our 3-county jurisdiction for resources through a type 3 team to effectively handle, an increased allocation of vaccines. So we've been on this journey for a month and a half now about, what we get for first and second doses. But if we start to plan ahead, how do we successfully get things ready to implement if we receive potentially a doubling of vaccines? So that's where a lot of the conversation is right now.
Thanks, Matt. I think that's an exciting problem to think about. I know for the hospitals right now, they want more doses, and I think everyone else does too. So we've definitely been part of building this infrastructure. All right, that I think is unless anyone else has more they'd like to say, that's our presentation, and we're happy to take any questions. I will note that Darren has to leave at 11:45. So if you have a question specific for Darren, we could start with those first, but you could put things in the chat, or you're welcome to unmute yourselves.
It's Allison from Cairo. May I ask Darren a question?
Sure.
Darren, you talked about needing to cancel those 7,000 appointments. Was that all delays because of weather, or just also what you're having trouble planning for what you're getting from the state and the feds?
Yeah, we typically start those scheduling of appointments when we have confirmation of the vaccine. So that was weather related and not a crowd pleaser for many to have to move those.
But
a lot of anxiety around getting the second shot and the time around it.
So a couple of, Darren, just to clarify, those are not cancellations, those are reschedulings.
Correct. Those are rescheduled appointments from last week to this week.
Right.
Yeah,
and
great question.
They're still going to occur within the clinically recommended time for the second dose.
Correct.
Yes. Maybe not people's dream time because they wanted to get them as people are, we've seen people wanting to, the second dose window starts a couple of days before the 3 weeks and the 4 weeks. People want to get in as fast as they can for the second dose. They know they're fully protected. So a week's delay, as Darren said, people did not love, but it's not a cancellation and they will get their second dose and it's still within the clinically recommended time.
Correct.
And it's a bummer. All those things are true. We wish that we could have gotten vaccine here faster.
Jessamine McIntyre here with Q13 Fox. I am curious about the influx you're about to get. You talked about, well, a couple of different people have talked about having the capacity to deliver a lot because supply has been the problem. Is this a good test run for when you do anticipate the federal government giving you more vaccine? And what is the plan?
Darren, you want to take that question about how many more could you handle than you're getting, maybe? Yeah.
If you've gone through one of these clinics or you've read about them, they're labor intensive. And so I think as soon as we can get other partners within our community doing the vaccinations, that's always ideal. But for us here, we've done quite a few with City of Lacey, so Thurston County and then Lewis County mass vaccination clinics. And so those have been dry runs for us. And I think we'll continue to work with the county to scale those up. So we've done a few on the weekends here, but they are labor intensive. And so we're going to have to work through that because we are pulling some staff out of the hospital operations to handle that. And I think that our other panelists are probably noticing the same effect.
Yeah, I think in UW Medicine, we've delivered nearly 100,000 doses now, but we've relied heavily on volunteerism and folks staffing our clinics. I personally have volunteered in the clinic and it's a great experience, but it is incredibly labor intensive. So I do think that rings true for us as well. We can handle doing many more and we want to continue to partner and do many more, but I think it's a lot of staffing.
I think just to remind folks of what's different about this kind of clinic versus a flu clinic. We have to screen for eligibility. With flu clinic, anybody who walks up and get a flu shot, so they need to make sure that they are either 1A or B1, and they have to you've got to have social distancing when you're administering the shot, and then you have to have a 15 and sometimes 30-minute waiting period after getting the shot with social distance and observation. So you need to have staff who are observing as well in case people need help. And a number of the hospital or bigger clinic sites have EMS folks right there in case someone needs emergency assistance. So it is quite a bit more labor intensive for sure. I think the other thing, happy for anyone else to chime in on this, that would be helpful for us in planning to scale up vaccines would be multi-week predictability. Still, the vaccine providers are not hearing what they're getting until Friday morning. And so with a goal of having to administer all of it or 95% of it in the following week. So if the hospitals and others, I think this is not just true to hospitals, I think everyone, if we could know you're getting 5,000 this week and 6,000 the next week and 7,000 the week after that, as a base allocation, and we might increase it if more comes, but then you could plan for staffing because sometimes the allocations have gone from 12,000 one week to 2,000 the next week or 5,000 one week to 0 the next week. And so that stopping and starting, I think is challenging. And I'm happy for anyone. Matt, I don't know if you want to comment on that.
Definitely still the struggle for us as well is that when we don't know what we'll get 1 week to the next in terms of trying to schedule things out, making sure that we have enough resources, that is very much one of the most significant issues that we've asked for more lead time. We believe that with the federal government giving the state at least 3 weeks notification of what we'll receive, that we'll start to get more information from Washington State Department of Health for what we as vaccine providers or areas will receive. We believe that that'll be forthcoming, but it can't come soon enough for us for certain.
Great. Okay, so we have a question. Go ahead.
Cassie, I just want to also mention one other thing about the complexity of the COVID vaccines. And, you know, with other vaccine types, they're usually single dose. And so it makes it a little bit easier. However, the COVID vaccines are all multi-dose. With Pfizer, you can get 5, 6, or 7 doses out of a vial. And Moderna, you can get 10, 11 doses out of a vial. And so we have to be careful that we're using every last drop of vaccine. You know, for flu shots, our staff has been used to delivering single dose for a long time. So it's just, you know, one shot, one person, and you walk out the door, and that's fine. But this is a little bit different in that we have to make sure that we're using up all of the doses in the vial. So we need at least that many people there. And then we also have to make sure that they come back on time for their second dose, which is unlike most other vaccines or boosters. And so there's just so many layers of complexity to this vaccine that we hadn't seen before, or you know, we weren't ready for it as much as we should have been. And so we had to get ready really quickly. But that's why most of us have to schedule people, and we have to make sure that we have the right allotment for them. So it's definitely a little bit more complicated than regular vaccines.
Yes, thanks, Christina. That's a great point. We have a question for the Tri-County team. Do you have a forecast for when you could be ready to begin vaccinating people in the next B1 level if the state was to give you permission to do so, or is that still too far off to think about? And I suspect this is aimed at you all because we can see from the DOH's map that the rural saturation in B1 is greater than it is in urban.
I could take just kind of a start at the response to that is that there are certainly a few counties around the state which believe that they're approaching saturation for tier 1 under phase 1B. But we also realize that most other counties, both large and small, are still very actively engaged in tier 1. So there is an understanding even where we have Ferry County, for example, that is getting close to reaching that saturation for the current eligibility group. There is that understanding that, you know, we've got a lot of work to do elsewhere in the state, especially with scarcity of resources for vaccine, that those vaccines will be directed elsewhere until we get to some point of ready to advance for the remaining, for those counties. What that threshold is going to be exactly, I think, is still a point of discussion and coordination with Department of Health and the governor's office about what that looks like. There's some guidance out there that talks about once 50% of that threshold is met for the current eligibility group that you can advance into. But those are conversations before we do advance that we'll have with DOH to make sure that there's good communication, good understanding about when that happens. But we're just not there yet.
Yeah, and I can speak for Pend Oreille County too, and just again reiterate, we still have 800 names on our list for people who fall into the current phase guidance, and so we're nowhere close to being saturated, and we're getting more names every day.
I think a couple of things to think about here too are that a tray of Pfizer goes a lot further in a rural community than it does in an urban community. So it can reach, just proportionally, it reaches more people. And we as a state organization want the state to move forward together. So the urban counties they're not behind because they are slow. They're behind because they have gotten less vaccine proportion to their population. So that's really important to note. So another question for the Northeast crew: do you expect to receive Johnson & Johnson vaccine? And if so, does it change your strategy, or how are you preparing for it?
As far as strategy goes, I'll take any vaccine we can get our hands on. And so typically, Pfizer is a little bit different because it requires it does require a couple of steps to get it ready. Moderna is pretty much just withdraw it from the syringe. I don't know enough yet about Johnson & Johnson, but I do know that we will take it if it's offered to us, and we will absolutely make anything work very quickly.
So I think, and Matt, I'd love for you to comment on this as well. What we have heard, and I don't think this is just decided policy, but is that hospitals are not very likely to be recipients of Johnson & Johnson because we actually have the ability to provide the storage for both Pfizer and Moderna, and also the clinical record keeping to get people back for a second dose. And so I think what I've heard from the state is that hospitals are likely to continue to be Pfizer first, Moderna second, and Johnson & Johnson third. And that might change. But Matt, maybe you've heard some conversations about that as well.
I think that's consistent with our understanding as well. But there's, to be honest, there's very little information. We know that Johnson & Johnson could receive that emergency use authorization later this month. But exactly how that will be doled out throughout the state is yet to be determined. But our understanding is similar to what you expressed, Cassie.
Great, thank you. I think a lot of community partners, like could housing departments or food banks or those, places that don't have the really cold storage, could they be recipients of Johnson & Johnson has been some of the conversation.
One thing.
Another question, Darren, I'm going to send this one to you. Are there enough low dead space syringes in Washington to get all the doses out of each vial, or is the supply of the low dead space syringes an issue?
Well, I'm not sure I even know how to answer that, Cassie. I have not heard any concerns so far at this point, but I think we're continuing to monitor the supplies needed to get the vaccines in. I'm not sure I know enough. I can research that and get back to you.
Anybody else? I actually do have some information about this. Anyone else have comments about low dead space syringes?
From Newport's perspective, we've had to order our own and not rely upon what is included in the ancillary kits. But of course, we're trying to get every dose out of these vials that we can. So we're always looking for a supply of that low dead volume syringes.
So I think we have heard from a number of hospitals that they are looking for these, and we've actually been trying to find a source. We found some good leads of folks that have them. So I can just give a quick explanation of this, and Dr. Critic, please correct me if I'm wrong. But what this means is that some syringes, you have to pull back more volume than you can actually inject. If you want to inject, some will always be left in the syringe. And so the low dead space means that they are really true, that what you pull up, you actually can inject all of it. And so you can count on they're much more efficient at getting all the doses out. And some of the kits that have arrived with vaccine have not had the low dead space syringes. And so hospitals and other providers are trying to source them. Matt, do you have any comment about that? Or Dr. Critic, anybody else want to
No, I think you described it perfectly, Cassie. I think it's us trying to get as much as we can, and that's what those syringes help do. When I volunteered in the vaccine clinic, I spent the better part of an hour drawing them up one day, and I think it is incredible how variable it is, so you do want to not waste it all.
So there's a question about how much vaccine has gone to waste without the supply of dead space syringes. I don't know the answer to that. I think it's, I think you can, Dr. Critic, please jump in here. I think you can pretty consistently get 6 doses out of Pfizer with the low dead space syringes, right?
That's true. And our waste has been incredibly low, at less than 1%, and in doing so. So yes, you can reliably, we estimate 6 doses per vial. We've gotten up to 8 doses depending on the vial.
So it's, I don't think any so the tricky thing is that what's been accounted for up till now, actually this is the first week, it looks like that they're counting the Pfizer trays as being 1170 versus 975. So they're counting on the 6 dose out of the Pfizer vials, but that's the allocation number. But nothing has gone to waste from the numbers the state has received. Everything has just been extra. So you can, I think even with a not low dead space syringes, you can get your 5 doses. It's whether or not you can get your 6 dose. And same with Moderna. I think you can pretty reliably get your 10 doses, and you can sometimes get 11 if you've got the right syringe. Okay. Another question, Dr. Critic, I think I'm going to send this one to you. When did hospitals start to have a noticeable drop in COVID patients, and how is this drop affecting workload for staff and morale? And then also, are there some examples, Dr. Critic, you noted about how staff are being thanked for the work they've done this past year. What kinds of strategies are you using to do that?
Sure. So in our system in UW Medicine, we started seeing numbers come down pretty reliably at the start of the year. So in January and over the last 6 weeks or so, we've seen steady decline probably kind of consistently downward since the start of January. And I think in general, that's been good for morale. I think the challenge is there's lots of patients who are coming to the hospital with things other than COVID, and we're still busy. And so our ICUs are still full and our inpatient units are still full. So I don't think it's been like no more business, it's just less patients with COVID. So that's definitely felt appreciably different. I think that helps morale. It also has this little paradoxical thing of you get revved up for an emergency and an event, and then all of a sudden you go back to doing business as usual, and that feels a little weird. So I think there are pluses and minuses in terms of morale. In terms of gratitude, I think we've done gratitude for within our institutions with our leaders, offering thanks, sharing thanks, both in small, recognition of people, we have a whole gratitude boards where people can write thanks to each other on the different teams. We have note cards that we've distributed throughout our institutions so people can thank each other. We've had an outpouring of gratitude again early in the pandemic, and then again from our community, sharing food and other small gifts to say thank you. We have a kudos board where people from the community can send in comments of thank yous that we broadcast across our institutions. So we're really thinking of lots of different ways to say thank you to people, and big and small opportunities. I think from the community, one of the hardest things is to see people not masking and not physically distancing. So I would say one of the greatest ways to say thank you to your healthcare team right now is to keep doing those things, to keep wearing the masks, to keep physically distancing, to keep having groups small and sticking strong, despite the fact that it's so easy and so understandable to be fatigued by that. That honestly, I think is the biggest gratitude we can get from the community, is kind of sticking with all of that. So we're trying to say thanks to each other. We're really appreciative of the community saying thanks to folks, and we're trying to share that broadly across our institution.
Thank you. I think that's a great answer. That's something we've said repeatedly, is the best way that you can show appreciation and gratitude for your healthcare workers is to not get COVID. They will care for you if you get COVID, and they don't want to do it. It is a terrible disease. So the frustration at seeing people get COVID exposed because they went to a wedding or they had a Super Bowl party or whatever is just really, it's very, very challenging for staff to feel like those are avoidable diseases. And we know what to do to keep people from getting sick.
This is Evan Bush over at the Seattle Times, and just wondering if you could help us understand how health organizations have accounted for the extra doses in data reported to the state to date, and then if you can expand on the policy change of the 6th dose being accounted for this week. Cassie, when did that happen? Who made that decision? And then is that essentially shifting the denominator for doses administered versus delivered? Yeah.
So I will say what I think about the policy, what I believe I understand, and Matt, you might know this as well. So once Pfizer recognized that people were pretty consistently getting a 6th dose out, I think they actually asked for the change, in part because they're getting paid for it. Now they're getting paid for 6 doses instead of 5 out of every vial. So I think that's just new this week, that the trays are now marked as 1170 instead of 975. Matt, am I right about these things I'm saying?
That's correct. So when they, previously when those allocations came to you, it was just based upon 5 doses times 195 vials, and they did recognize that. So when those show up as vaccines received, when you get that full tray, now it actually does represent the 6th dose for 1,170, and that was a change this week, correct?
Right, and I think Pfizer was the institutor of that change, as I understand it. The way that this has been one of the things we talked about how the immunization information system data is reported. You don't report that Newport received 975 doses and vaccinated 975 people. And as a body, you report we received 975 doses and we vaccinated these 1,010 people by name. We vaccinated, Jim Johnson and Sally Clark or whatever, you have their individual names. So they would have shown up in any extra dose will be accounted for as administered in the data the state has. It's been a little tricky to match up second doses. sometimes, because especially if there's a syringe change and you had a better syringe at one point and now you have a less good syringe, you still need to make sure you've got enough doses to get all those folks their second doses. That's been a little bit of a wrinkle in second doses. I think the state's done a good job of addressing it. Anybody else want to comment on that?
I would just add, this is Matt. I think it's a good change because it was hard to reconcile first and second doses where, to get the correct second allocation for that first batch became problematic. So I think it's beneficial, some of the changes that have been made in this regard in terms of recognizing the sixth dose, that we are assured the correct dosage the next time. And then the other part is that, just the reconciliation process that has been ongoing for the past 2 weeks to try to bring about more of a balance on first and second doses, because that has been something that we've all been challenged with for the last 2 weeks.
Matt, it's Evan Bush again over at the Seattle Times. Could you expand on the type 1 and type 3 incident management teams and just help us understand what that means? And also, is that being organized, I'm sure, at the state level? Help us understand how that's being affected.
Yeah, and I'll explain it to the best of my ability, because this is, things are happening fairly rapidly with standing up these teams. So approximately a week and a half ago, we received notification by both the Washington State Department of Emergency Management and Washington State Department of Health that they were making available type 3 teams, incident management teams, to regions based upon the roadmap to recovery regions. So for us in Eastern Washington, that would be a total of 9 counties. What they made those teams available for would be any 2 counties or more that wanted to submit that request for an incident management team could do so. Given that we were already a 3-county health jurisdiction led by our incident commander, Dr. Artsis, who's our health officer, we submitted for one of those teams because we were really trying to project ahead of where we're at right now, just thinking ahead for the next month if we needed to increase our ability to vaccinate individuals in our area, what were some of the resources that we needed. And so we submitted for that team. That process is happening hand in hand within a state effort to institute a type 1 team. So when you think about large events in the nation's history, those are type 1 teams. That's the biggest team that could be allocated towards a response. So if we think about the leak in the Gulf a few years back, or Katrina, or large weather events, those are type 1 teams that help with the logistics, the operation, fiscal responsibilities, just that structure that incident command brings to a response is something that I think there's a recognition that there needs to be this coordinated effort that's expanded at the state level, hence the type 1 team, and then knowing that there could be specific needs within regions or multi-county areas for type 3 teams. So this is not designed to replace some of the existing infrastructure or abilities that we say that we have within our area. It's to complement that. So, for example, if we saw more vaccines come into our area, how would we coordinate as a health district with Newport Hospital and Health Services? If we needed to stand up larger vaccination sites, how could we combine our efforts, but also tap into some of those state resources to help with the scheduling? That's a massive lift for all of us to do, to schedule out both first and second doses, do callbacks, reminders, staff that from a clinical side, from a operations side, just to handle traffic flow and people. Us within at least Northeast Tri-County, we don't have a mass vaccination site. And as Jenny said, most people would rather attend something closer to where they live or their county of residence. So we need some resources to make those things happen in a larger perspective. And so that's why we asked that team to provide assistance to us.
Thank you. And I think another important point, we've had this question a number of times, is why don't we just have people sort of line up? Why do we go through all the scheduling process? And at least in the phase we're in now, there's so many folks who, for whom the idea of getting up really early or standing in a long line just can't work for people in the age groups that we're targeting. So the scheduling that Matt is describing is really important. Any other questions? I want to conclude with gratitude for the power companies of Washington State and the water companies. I think we are all really worried about, I have got a lot of family in Texas, and they were in hotels and people were going to warming centers and such. And I think it's worrisome that how many people might have been in crowded spaces. So the fact that our power companies kept our lights on and our heat going during our snowstorm is exceptionally helpful for COVID as well. So very much thanks to them. I think, Beth, you said there's one more question, but I can't see it. Can you read it out loud?
Sure. This is from Ellis O'Neill. It's on the low dead space syringes. Does that mean that the percent administered reported by the state is an overestimate? Because in the data, it would appear that some providers have administered more than 100% of the doses they've received.
Oh boy, I don't know.
So one of the things about the appearing to have administered more than 100% does account for that extra dose. Right.
You know, that's going to have to be a question for DOH. I don't know how they're counting the denominator. Anybody else know? Sorry, I really don't know. All right. Thanks so much for joining us. We'll be back here next week. Thank you so much to our panelists. Really appreciate your time and your expertise and your dedication to our communities. And we're all excited that the vaccine is on its way, winging its way to Washington State, and we're eager to deliver life-saving vaccine to